By this ileostomy, he underwent an anterior resection for a rectal tumor laparoscopically. Anterior resection for a rectal tumor laparoscopically. Now, can you refine your answer?
Defunctioning loop ileostomy.
It's a defunctioning.
Loop ileostomy. Loop
It's a
ileostomy.
defunctioning
Loop ileostomy.
loop ileostomy. It's a defunctioning loop ileostomy. So you expect two limbs, the proximal limb and the distal limb. What is this one? It's a proximal limb. Why do you spout it out? What is it? It's a spouted out limb. Why do you spout it out?
Autodigestion. Prevent the autodigestion of zero.
Huh?
Prevent the autodigestion of zero sample.
To prevent the autodigestion of?
Prevent skin adhesions.
So, what is that theory? Heard it today only.
Partially correct.
මොකද කියන්නේ මට තේරෙන්නේ නැහැ.
Autodigestion of adventitia.
Adventitia. Where do you get adventitia?
Serosa.
Serosa. Serosa surface of the bowel. That answer
Prevent
is
skin adhesions. Skin adhesions.
like you get about 20% out of 100 if you give that answer. Because the initial part is quite correct. The latter part take a වැඩක්ම නැති කරායි answer. Yeah, that's not the reason why you do it, because you want to prevent skin exfoliation, because pancreatic juices and intestinal secretions are very irritating. But why do you not do it for the colostomy? Have you seen colostomies? So why do you not do it for the colostomy?
It's not corrosive. It's not. The juices
You
are
get forms
corrosive.
too, right? නැත්නම් අපේ anus එකත් irritate වෙනවද? එහෙම වෙන්නේ නැහැ.
ඒක loose stools වෙලාම irritate වෙනවා.
Huh? Yeah.
Stools වෙනවා.
Yeah, loose stools උනාම irritate වෙනවනේ. Irritate වෙන්නේ, that is because you get loose stools because the absorption process is not completed. So you get intestinal contents coming out. So that's why if you have a lot of loose stool coming out in a patient, you get perianal excoriation. Same principle here. So that is why you want to prevent it. So you get this proximal lens spouted out at 7 o'clock position. So you can place a bag nicely so that it can come into the bag. Directly come into the bag. What do you do if there is by any chance skin excoriation? How do you manage it? A patient with a colostomy bag or a ileostomy bag has skin excoriation. How do you manage it? Yes. So there are certain products available.
Cream.
නැද්ද මොනවද කියලා තමයි Stoma class එක කරලා
Stoma
Huh? Yeah, there are commercially available preparations to prevent skin excoriation. So you apply that
Skin.
over the skin. So zinc oxide is one important preparation like that. And if this doesn't fit enough properly, there are things called coloplast and paste-like thing where you can paste it on the skin and apply it so that it fits in nicely. Most of the time this excoriation occurs because this doesn't fit in properly and things start seeping in. Okay. So what are the complications of a stoma? Sure. Okay. What are the complications of a stoma?
Early complications.
Anybody? So, don't list out.
Early complications.
So you have
Early complications.
early complications
Late
and late complications. So what are the early complications?
bleeding.
Okay, bleeding is very rare. It's not retraction. Ischemia. Retraction and ischemia. And maybe, like you said, unnecessary or undue protrusion. Right? Most important two things are retraction and ischemia. Those are the two things that we are worried about. You do a stoma and if it is ischemic, what will you do? The next day you see it's ischemic. It's black color, off color. What do you do? the management depends on the severity of the ischemia. Okay? If the ischemia is only confined above the level of the rectus, you can manage it conservatively. If it is extending below the level of the rectus sheath, then you have to refashion it. So how do you know whether it is above the level or below the level of the rectus? medium බල්ලා කියන්න බෑනේ. දිවස් තියෙනවා medium කියන්නේ. එහෙම කියන්න බෑ. Yeah. Ultrasound. Yeah, you put a scope in. That's one way. Put a scope in. Or the second possibility is you take a glass tube and you pass the glass tube along the stoma. When you pass this glass tube along the stoma, you will be able to see the extent of the ischemia, and it goes nicely through the rectus sheath into the abdomen, into the peritoneal cavity. Into the peritoneal cavity is, what I mean is the portion of the bowel within the peritoneal cavity also can be visualized if you pass a glass tube, and if you flash a light to it, you will be able to see it nicely. So if it extends beyond the level of the rectus sheath, then that requires refashioning. Understood? Right. So those are acute things, early things. What are the late complications?
Stenosis. Periostoma hernia. Stenosis.
Good. Okay. Stricture formation. You recently saw a patient. Remember Sebastian? Sebastian had that problem. Right. Okay. That's number one. Okay. Number two. Is it common? It's very uncommon. It's very uncommon. Right.
Periostoma hernia.
Herniation, yes. What is that called?
Periostoma hernia.
Huh? A parastoma. That it has been given a specific parastoma. There are several types. There are 4 types of parastoma. And they will not have that. It's a little difficult to remember. Don't worry about it. But parastoma. So, what is the percentage of parastoma hernias? See, is it common? It is very common. It is very common. Half of the stomas that we do will end up with some degree of a parastoma. It's about 50%. It's not just us, other figures are like that. So this patient also has a parostomal hernia. Right? It's not that evident. Some patients you will have a protruding stoma like this, protruding herniation like this, like a big bulge. What is the problem with the parastoma? What is the problem with the parastoma? Can lead to obstruction. One problem is that's the acute problem. They can present with intestinal obstruction. If a bowel loop gets stuck in to a hernia sac in this parastoma hernia, you can have obstruction. It's very bad. Number 2.
Strangulation.
Okay, obstruction, just like obstruction, you can have strangulation of bowel loops. Yes, correct. Anything else? What's the more worrying problem? I mean, that is a really bad thing to happen. In which case, it's an urgent surgery actually. If not, what is the usual problem with parastoma hernia? They will have this. What did he complain? When he sat on the bed, he immediately said something to me. What did he say? Exactly, he has trouble getting this fitted on. Okay, what do you call this part? Call the base plate. He has trouble keeping the base plate fitted on. That's the problem with the parastoma. That's why he has this belt going around it. So what are we doing for the parastoma hernia at the moment? We are conservatively managing it. Can't you see that we are conservatively managing it with a belt like this? Right? So parastoma hernia is a major problem. So what you do for a parastoma hernia, conservatively managing, is one now. Right? Okay. So how do you manage? What are the other options? It depends on the severity of the problem. If the patient presents with an acute intestinal obstruction for a parastomal hernia, you will have to urgently operate. Okay? Let's say it's not an acute thing. something like a chronic problem. Patient has a bit of pain and problems with sticking this in and all those. So how do you manage? Then again, it depends on the severity of the problem. If the problem is really bad that he can't actually do his day-to-day work, then he requires intervention. Otherwise, he will be managed conservatively like this. If intervention is required, then the decision depends on what? What's the next most important thing that makes the decision?
Time.
Huh? Now we have created a stoma for some reason. Exactly, whether that stoma's purpose have been served or not. Now in this patient, has it been served now? Yes, it has been 2 months. 2 months have elapsed from the day of surgery. We put the stoma for defunctioning purposes because he was given neoadjuvant chemoradiotherapy and we were not sure about the anastomosis. We wanted to defunction that anastomosis. So that has been done. Now we have to reverse it. So purpose has been served. So if the purpose has been served, then you maintain the bowel continuity by doing an ideal anastomosis and then repair the stoma repair the hernia at that time, at the same time of surgery. That's what you do. But if the purpose has not been served, for example, let's say it's an end colostomy for let's say APR. Patient has had an APR, so it's an end colostomy. It's a permanent thing. Patient has to have it. Then, if there is a requirement for intervention for the parastomal hernia, that is because patient is having a lot of problems with it, then you resite it. Then you will have to resite it. Understood? That's how the management of parastomal hernias go. Clear? Right. So, parastomal hernia, stricture formation, stenosis. Skin excoriation. Those are the other problems associated with the stoma. Right? Okay. Right. Okay. සමහරවිට එනම් අපිට මේකේ පේන විදිහට පොඩි ස්ටොක් hernia එකක් තියෙනකොට පහින්න බලන්න. You see it's bulging out. It's bulging out. It's not that bad, but since he can be offered surgery to reverse this, we can proceed with that. So if you want to reverse a stoma like this, what is the next most important thing you have to make sure? Patient has had a major surgery. How going to be a major surgery? Huh? Exactly. So, how do you ensure that patient is going to have normal bowel? At least 1 minute. Patient auscultate කරන්න නෙවෙයි ස්ලබ්ස් දාන්න. Yeah? DRE නෙමෙයි මොකද්ද බලන්නේ DRE කියලා.
Rectum.
You have to make sure that there is no anastomotic stricture. If you reverse this, and if there is a down anastomotic stricture, what patient is going to have? Intestinal obstruction. So you have to make sure that anastomosis is quite good. So one thing that you can do is a digital rectal examination because it's a lower down anastomosis. කලින් වගේ rectal examination එකක් කරලා බලන්න. හොඳයි? පොඩ මඩ බලන්න ඕන අපි අර කලින් ඔපරේට් කරපු දන හොඳයිද කියලා. මේක රිවර්ස් කරන්න බලන්න. අර කකුල නවාගෙන මඩපැත්තට. Okay. So I can feel the anastomosis. It's quite alright. In the stapler line, I can get my finger above the stapler line. Okay? So that means the anastomosis. If I can pass my finger, that means there's no stricture. Right. Okay. So what is the other thing that I will do at this moment? Huh? Sphincter tones, exactly. අල්ලගන්න නැහැ. බුද මාර්ගයෙන් හත කරලා අල්ලගන්න. අර මලපා කරන පිට වෙනකොට මුරුල් කරනවා වගේ බුද මාර්ගයේ අතමලා අපි මලපා පිට කරනවා වගේ අපි මලපා පිට කරන්නේ නැතුව හත කරලා අල්ලගන්න අපි කපාටේ තද කරගෙන අන්න ඒ වගේ හත කරලා අල්ලගන්න. Very good. Excellent. Right. So that's very good. Right. Okay. So he has good squeeze pressure. So what are the types of pressures in your sphincter? You have a resting pressure and a squeeze pressure. Now, if you do a rectal examination on this patient, you will realize his resting pressure is so low. Mama angle දාපු ගමන් just අක්කල angle ඇතුළට යනවා. Why? There is no reason for him to have resting pressure because now it's defunction. So over time, the out of the two sphincters, which gives the resting and which gives the squeezing? External gives the
Squeezing.
external gives the squeezing. Internal gives the resting. External is the one that gets the pudendal nerve supply or the somatic nerve supply. It's the one that we consciously constrict, right? So it's the internal one which is now totally relaxed because it has no reason to function. So his resting tone is not there at all. But when I tell him to squeeze it, he could squeeze it. So that means its pudendal nerve is quite intact. So we have to make sure that his sphincter tones are good. We have to make sure that the anastomosis is good. What is the third thing that we have to make sure? If you are going to reverse. Huh? There's no leaking, no. Obviously, you can have a leak after two months. You want to make sure that the rest of the bubble is also okay. My finger went up to 5 centimeters, no, 7.5 centimeters. He has about 100 or 150 centimeters of large bubble left from the point of reversal. So you have to make sure that the rest is quite all right. How do you know that? How do you do that? Colonoscopy. Okay. So 3 things: sphincter tones, anastomosis, rest of the bubble, plus any complication of the stoma. These are the 4 things we are concerned if we are going to reverse a stoma. Understood? Right. Okay. Okay, Mr. Amdul, අපි හිමු මේක රිවර්ස් කරමු. ඊට කලින් මට කැමරා එකක් දාලා ඔයාගේ බව එක බලා ගන්න අවශ්‍යයි. මේ විදිහට දෙන්න. Yeah, we can. It's flushed to the skin. That's why you only see the spouting part of it, which is a proximal part. But if you take a puttak may pattern available, a distal opening of it, actually you can put a finger in through that. Shanurudhi, it was not good. Then what? Yes. Okay. That's the next step. Not the immediate next step. Step after that. But before that, there is another thing that we can do. Now, I did only a digital rectal exam. Is it objective or subjective? It's subjective. It's subjective to me. It's not an objective assessment. So, is there an objective assessment of these sphincters? Huh? Sorry?
Measure pressure.
Huh? So, how do you objectively assess this? Something like that. But there is an easier way of doing it. You instill about 150 to 200 milliliters of saline into the rectum and get the patient to hold it in. You ask the patient to stand up and get the patient to hold it in for 10 minutes. This is called saline retention test. If the patient can do it, that means his squeezing pressures are good. Although my fingers sensitivity to squeeze pressure was not good enough, right? Okay, angular dala beluwa mata ahunne squeeze pressure was not good කියලා මට හිතුනේ, but now he can retain. So that means his squeeze pressures are good. So that means it can be reversed. But if he can't do it, If the saline retention test is he fails that test, then what will you do? Then comes his plan. That is, you get him to train his fingers. So what is that called? What are those called? They are called Kegel exercises, pelvic floor exercises. Right? So you train them, you send the patient to a physiotherapist. If you become a house officer in Colombo professorial unit, by any chance, you have to do all these things. That's why I'm teaching you these things. You have to do the saline retention test for the patient. You have to get the patient to stand up for 10 minutes and check whether the patient is capable of holding it in. And if not, then you have to send the patient for Kegel exercises for physiotherapy, because they do all that there. All of that is being done there. That protocol is, the textbook protocol is being properly followed up there in that unit. We don't stick to that much here. Most of the units don't. Okay, so that's what you do. So you send the patient for Kegel exercise and get the patient back in 1 month's time and reassess. And reassess and see whether the patient can hold the stool in. Right? Oh, sorry. Do the saline. Hold the saline in. Saline retention test again. And if the patient passes it this time, then yes, you offer the patient surgery. If not, then you go for subsequent investigations like anorectal manometries, MRIs, nerve conduction studies and all that in a protocol. You don't need to know that much. Right? Okay. Any questions? Then you have to recite. So when you recite, what you mean by recite is or refashion, either one of those. Refashion the stoma. At the time of refashioning, you have to repair the hernia. If the refashioning is not going to be helpful for repairing the stoma, then you have to recite. When you recite, that means you bring it somewhere else in an unorthodox place. That sometimes you have to do it. Refashioning means refashioning of the stoma. Let's say the stoma, when you have parastomal hernias, even the stoma side gets a little distorted and problematic. So sometimes repairing the parastomal hernia is not possible without refashioning the stoma. So you have to refashion the stoma as well as repair the parastomal hernia together. If you can't do that, then you have to recite it and repair the. The repairing of the parastomal hernia, if it results in significant problems with the stoma subsequently, then you will have to recite. And it's a surgeon's decision. They will not ask those details from you, or they will just want to know. This is a very common case in the exam in stoma. So they will ask, what is this? What is the stoma? Why do you think the stoma has been put? Right? So then you have to examine the rest of the abdomen and say the stoma, it is like if you see a midline incision, very likely that the patient has had a bowel surgery and a defunctioning has been done or whatever. If you are not sure what exactly is happening, I would like to ask the patient a few more details and find out what the patient has had. Right? Depending on that, you can ascertain what sort of a stoma it is and all, why it has been done, because sometimes you will see a stoma here for a Hartmann's procedure. If you do a Hartmann's procedure, that does not mean that it is a permanent stoma. That means there is a possibility 80% of the time we will be able to reverse the Hartmann's, isn't it? So therefore, if you see a colostomy, you have to ask the patient for what it was done. Did he come with bowel obstruction and that is why we put a Hartmann's? Or has he had an abdominal perineal resection? So you have to tell the examiner, I would like to examine his perineum to see whether the patient's anal canal has been closed off. If you do an APR, you close it off, isn't it? So you can ask that from the patient also. But of course, you offer the examiner that you want to examine. So these are the things that if you are given a case of a stoma in the exam, you have to make sure that you examine the rest of the abdomen, make sure what the scars the patient had, and try to explain what the scars are. So if you see a midline laparotomy scar, you mention it. There's a midline laparotomy scar, which is if there is associated hernia, you have to comment on those. Or you say there's a midline laparotomy scar, which is uncomplicated, and then there is a ideal stoma. I would like to ask a few questions from the patient to ascertain why this stoma was put in. And of course, I would like to do a digital rectal examination. That's right. So you need to remember why all the things that I told to back in that, because it's an it's not a very common. It's a common exam spot for you. Spot, not a spot. I mean, it's an station for you. But it's not something that you usually are familiar with. Batting now. Hernia එකක් දුන්නාම දන්නවනේ කරගෙන යන්න ඕනේ. Stoma එකක් දුන්නාම කරගෙන යන්න ඕනේ විදිය තේරෙන්නේ නැහැනේ ගොඩක් කරා. ඒක නිසා you request for patient's history and previous details. ඒක හැමතිස්සෙම එහෙමයි. කතා කරලා තමයි ඒක ගොඩ දාගන්නේ. And then they will ask, okay, what are the things you are looking for as complications? Then you have to tell the things that I told you. Early complication, the late complication. It looks like this. Another thing is whether the stoma has been nicely matured enough. Stoma එක කල් යනකොට හොඳට mature වෙලා හොඳට තියෙනවා, right? This is a matured stoma now. If it's an early stoma, you will see a little bit of edema around it. දැන් ගොඩක් වෙලාවට ඔයගොල්ලන්ට stomas කියලා හම්බ වෙන්නේ exam එකේදී අපි ඊට කලින් දවසේ කරපු stoma එකක්. So sometimes you will see that there is edema. So you have to comment on it. I see edema. පිම්බිලා වගේ තියෙනවා. I see edema on this one. ඒ වගේ comment කරන්න. Or if it is like an old one like this, instead of spout out, it's a mature එකක්. It's a mature stoma. Skin excoriation and how the base plate is appeared, and if the base plate has been connected with a belt like that, so you have to say that patient has probably had trouble with the base plate, and that is why he is having this appliance, and check for parastomal hernia. And you have to offer the examiner, I would like to wear gloves and check, remove the bag and see the skin surrounding skin excoriation. Those are the things, those are the problems that you want to handle in case of stoma.
The duration of defunctioning depends on the patient.
It depends on the patient. No, it's not necessarily. Now, let's say if you put a defunctioning stoma, you can reverse it in 2 months, 8 weeks, 6 to 8 weeks. You can reverse it. Right? So it depends. If you do a Hartmann's after about 2 months, and make sure that most of the time, why do we do a Hartmann? It's an emergency thing, you know. They present with bowel obstruction, and if you have a sigmoid colonic tumor and the bowel is not prepared for us to provide with a anastomosis, most of the time what we do is Hartmann's procedure. But there is, like I told you that, you know, there are about 3 options where you can first do an on-table lavage, get the bowel to be cleaned properly, and do a primary anastomosis. Then you make sure that you are sure the patient doesn't have any stoma left. But that is a risky thing because unprepared bowel, it can leak. The second option is this. Second option is if you have a left-sided colonic tumor, you put a stent. Get the anatomy correct, get the physiology corrected, get the patient to be staged properly. Later on, go and do an elective. That's a very good option. It was not there until recently. Stenting was not there first. Very recently only we got this. So stenting, primary resection and anastomosis, and then what is the other possibility? If you have a left-sided colonic or rectal tumor, especially a rectal one. Not to do an Hartmann's, actually the other possibility, you do a transverse colostomy. Transverse colostomy, do the CT, and if it is a rectal tumor, do MRI and stage it properly, and then go and do an elective, required neoadjuvant, you give neoadjuvant for a rectal, and then subsequently do as an elective case. Right? And you have a nice stoma here now, so you can do a good AR, and you don't have to worry about putting an angiostomy because the patient already has a transverse colostomy. It's defunctioning already, isn't it? So that's like the third option. And the fourth option, of course, is Hartmann's. So Hartmann's, when patients come with a Hartmann's, in colostomy, so it can be due to a Hartmann's or it could be due to an APR also. So that is why you have to offer the examiner, or you have to tell the examiner that I want to check the peritoneal region.
So we can put an ileostomy instead of the transverse.
Yes. Instead of a transverse colostomy, you can put an ileostomy. I think I talked to you that day. What are the problems with the transverse colostomy? That is the problem. Handling the stoma appliance is a problem with the transverse colostomy because it's not a very feasible area. The problem with the ileostomy is that it is not physiological. It's less physiological rather. it's the transverse colon is better in terms of pros and cons. All.
Sir, when do we put double barrel stomas?
Double barrel stomas, again, it's just like, let's say, for example, I am trying to remember the last time I put a double barrel. Double barrel stoma, we rarely do that, actually, right? Double barrel is when you completely divide the bowel. Bowel becomes that loop again. You get the loop, make an incision on the bowel and get it out. So it's a loop. You understand by loop? Double barrel is when you completely divide the bowel. So you have two ends. You have a proximal end and a distal end. So you bring the proximal end as a stoma and the distal end as a mucus fistula. The distal end will not produce anything other than mucus, isn't it? So you bring it up. The reason why you don't want to clip it and keep it inside the abdomen is if we keep on producing mucus, and then patient will have problems passing it down from down there. So that's why you bring it up. So you do it in cases where, let's say, patient comes to you with acute abdominal pain, severe abdominal pain, and it turns out to be a condition where the patient has bowel ischemia and bowel infarction. You go in and you see a segment of the bowel is now infarcted, totally gone. You resect that segment, small bowel loop. You resect that small bowel loop, and now you are left with two bowel ends. And if the patient is not stable enough for a anastomosis, primary anastomosis. Most of the time, these patients with mesenteric ischemia, mesenteric infarctions, mesenteric ischemia, and bowel infarction, they come to you at a stage where they are hemodynamically totally unstable. Right? So if the patient is hemodynamically unstable, you can't spend time for anastomosis because it takes a little longer. And the other problem with hemodynamic unstable patients doing anastomosis is likely to fail because there's less blood supply to the anastomosis. It's likely to fail. So in that case, you don't want to take that risk. You bring it out. Stoma is the best option, right? So you bring it out. So in that case, you create a double barrel. So double barrel you can do at the same stoma side. You create just like that. You take a coin-like skin out, and you bring both at the same. So that is what is called as double barrel. Two barrels coming out. Sometimes you can't do it because that distal bowel you can't bring it to the same place. It's so far away, so you might have to do two stomas. One end stoma and the other one is mucus fistula. So it depends on the surgery, it depends on the circumstances. Right. Any questions?